Hello, I'm Jyoti Attry, Interim Director for Health and Wellbeing, and I'll be hosting the event today. This is the sixth in the series of webinars organised by Public Health Cymru on COVID and its consequences, and today's event will focus on COVID inequalities, and we're very lucky to have Professor Claire Bamborough presenting today, who I'm sure will need no introduction to many of you. I've had a little sneak preview at her slides, and we've got a very interesting session ahead for us. But I just wanted to start by setting some context before I hand over to Claire. In Wales, we had started to see life expectancy falter. The gains that we had seen over the last century weren't climbing as fast as we had previously seen them climb in Wales. And we already had a gap between Wales and England. And the COVID experience will no doubt threaten that even further. If we look at why we had that gap was also seen within Wales between those people living in the poorest areas and those living in more affluent areas. And a similar picture was observed for healthy life expectancy, with approximately a 2-year gap between those living in the poorest areas and those living in the most wealthy areas. And the reasons for that are probably largely structural, which manifests in differences in chronic diseases between those two groups, higher rates of cardiovascular disease, cancers and so on, driven by higher rates of clinical risk factors like hypertension and high blood glucose, which in turn are driven by people's behavioural risk factors, whether they smoke or their diet and so on, which will again be influenced by how good you feel, your mental well-being, which is driven by the wider determinants like your income, your educational status, the type of work that you do. And when we look at the COVID experience, we can see a similar picture. So people living in the most deprived areas were much more likely to test positive with COVID, to go to hospital with COVID, and to die from COVID. And again, structural factors must have played a part in that. And some of the factors that may have contributed to those differences are that people who live in the most deprived quintiles might have been more likely to have to physically attend work. They might have been more likely to work in the care sector or food processing plants, where we did see many outbreaks throughout the COVID pandemic and even in lockdown. It's possible that the areas they live in are more densely populated, or that they live in more overcrowded housing. And in some of the factory outbreaks that we saw, there were lots of other factors that were contributing to the higher risk. For example, the lack of sick pay. There were often migrant workers living in overcrowded accommodation, and even hot bedding. Of course, the other factors that I described previously will also have been playing a part, particularly in the higher risk, the higher likelihood of attending hospital or dying from COVID, and that will be because, not because COVID in itself has caused inequalities, more that it has exposed those pre-existing inequalities in terms of differences in risk of cardiovascular disease, cancers, respiratory disease, and the underlying determinants that I've already described. And there is also considerable concern that the measures taken to control COVID, lockdown and the fire break, will have had further implications and will continue to have implications for inequalities in the coming years in terms of employment and income, which will disproportionately affect those living in the poorest areas. But I'm sure we will hear a lot more detail about all of that from Professor Bamborough, who is, for those of you who do need an introduction, Professor of Public Health at the Faculty of Medical Sciences at Newcastle University. She's published widely and is a member of many large-scale collaborations, including the Centre for Global Health Inequalities Research and FUSE, the Centre for Translational Research in Public Health. So I'll hand over to Claire now.
Okay, thank you everyone. Thanks for that kind introduction and providing some extra detail about the Welsh context. So yes, I'm Claire Bamborough. I'm Professor of Public Health, Newcastle University, and I'm going to be talking today about some of these aspects of inequality, how COVID-19 is playing out as an unequal pandemic. Probably talk for half an hour or so, and then hopefully we can have some questions and discussion. In my talk, I'm going to reflect a little bit first of all about what we know about inequalities in pandemics from looking at some of the historical data. I'll then overview a bit of data about some of the emerging epidemiology around inequalities in COVID-19, reflecting a little bit about what Jyoti was talking about in the introduction, and then I'll introduce the concept of the syndemic pandemic, drawing on the work of Meryl Singer to think about why inequalities in COVID have emerged and how in turn COVID could exacerbate existing social and economic inequalities. I'll then focus in a little bit about the economic crisis that is emerging and is likely to exacerbate over the next few months. And then I'll argue about how we can not have to engage with this debate in the media about choosing health or wealth, public health or the economy, but argue that actually there is a middle way, and that's through the effective use of social safety nets to protect people in times of economic crisis. And then I'll conclude with a few thoughts about the implications for policy and practice. So first of all, I wanted us to have a little think. COVID hit us kind of, particularly those of us working largely in chronic disease and applied public health, certainly as a personal reflection, as a bit of a kind of a shock. I can say that I never thought in my career I would be really focusing on infectious diseases to the extent that I have this year, and I'm sure that's probably true for a lot of you as well. And so when COVID first broke, I spent some time analysing and examining historical research about what had happened in previous pandemics, what happened in terms of inequalities, and of course the biggest parallel being drawn between COVID and the Spanish flu pandemic in 1918. Now, of course, the Spanish flu hit at the end of the First World War. Transmission largely came into England and Wales through army movements, through ports, but what we can see is that data from places like as wide-ranging as Norway, Sweden and the United States shows that there were inequalities in Spanish flu. So 50 to 100 million people died from Spanish flu between 1918 and 1919. So obviously a much higher mortality rate than we've thankfully had from COVID-19. But within that, there was evidence from the historical records around higher incidence and mortality amongst, for example, the working classes of Chicago, amongst unemployed groups in Stockholm, and in lower occupational groups in Oslo in Norway. And I'll come on to an example in a moment. Within England and Wales, data by people like Rutter and colleagues shown an urban-rural divide in 1918, with mortality rates 30 to 40% higher in urban areas. This is an example of some of these inequalities in 1918, taken from the research of Sven Erik Mamland, who's a historian working from looking at data from Oslo, and which was called Christiana in 1918. And he examined data from the Groningen-Wexels area and the Frogner area of Oslo, so the east, the poorer area of the city compared to the more affluent west. And looking in 100 years ago, he found that mortality was almost 50% higher in the poorest areas from Spanish flu, and that he found by looking and using the number of rooms in a household, in an apartment, as a measure of socio-economic status. He found that there was almost like a dose response, so people living in larger properties, therefore more affluent people, had a much lower rate of mortality than people in overcrowded one-bedroom accommodation. So we can see these patterns of inequality emerging there by income and neighbourhood within Oslo 100 years ago. Together with some colleagues from the University of Leeds and a historian from the University of Cambridge, this week we published some work looking at regional inequalities in the flu pandemic in 1918, looking at England and Wales. And this map here on the right is showing the area divided into quintiles of mortality. So the darker the area, the higher the mortality rates from Spanish flu. And I think the first thing you notice in this is how high the mortality rates were. These are crude, unadjusted rates from the Registrar General's data from the compilation he put together in 1918. But we can see that some of the highest areas, such as Hebburn and Jarrow in Durham in the northeast of England, the mortality rates were almost 1,200 per 100,000, the crude mortality rates. And then other areas were in some of the southern parts of the country were less than 200 per 100,000. And you can see this geographical patterning with much higher rates in the Midlands, in the northern parts of England, and to some extent in some of the coastal areas, perhaps here attached to the troop movements that I mentioned. Equally in Wales, we can see higher rates, particularly here in the southern mid parts of Wales. So there was a north-south health divide in terms of the 1918 pandemic. There were regional inequalities. I also want to reflect on what happened in what's sort of sometimes been referred to, certainly Andy Burnham, Mayor of Manchester, who was at the time Secretary of State for Health, refers to the H1N1 swine flu as the pandemic that never actually sort of turned into a pandemic. But there was mortality from H1N1. And I know a number of you would have been involved in that from a public health practice perspective. And there's data showing that actually, again, similar to 1918, mortality rates were higher in urban compared to rural areas of England. And we can see in this chart here, the table, that there was inequalities with the most deprived neighbourhoods having 3 times the death rates of the least deprived. Of course, the big contrast is how low that mortality rate was from H1N1, particularly in comparison to the Spanish flu that we just looked at. And again, looking internationally, there's data from places like Canada and the USA showing that, for example, H1N1 hospitalisation rates were associated with deprivation, neighbourhood deprivation, or individual level educational attainment. So that's some of the kind of historical evidence that, despite claims certainly in the 1920s, and we had a little bit of the claims early on in this pandemic by some of our politicians in the UK that, you know, we're all in the pandemic together. And in some ways that's true, but it's also true that some people, some groups, some neighbourhoods, some regions experience the full brunt of the adverse outcomes of the pandemic. Some of us are rather inconvenienced, others are actually dying and being hospitalised. And we can see those inequalities in 1918, we can see them in 2009. And as I'll show now, reflecting on Yoti's introduction, we're also beginning to see very clear data around inequalities in COVID-19 outcomes, so hospitalisations, mortality, and to some extent also cases and infections. So here on the left-hand side is a chart early from the pandemic, looking at data from the United States, which was very badly hit during the first wave. And this is looking at inequalities by the level of the percentage of people living in a county in the US below the poverty line. So here you've got less than 5% of people living in the poverty in that county, and here on the y-axis you've got the COVID-19 death rate per 100,000. So in the places that have the least poverty rates, the lowest poverty rates, then the mortality rate was around 10 per 100,000. And then if we look at the places where counties in the US where you had over 20% of people living in poverty, then the mortality rate is over 19 per 100,000. And of course, these neighbourhoods also have high proportions of people from Black and minority ethnic groups as well. This chart here reflects from what we're calling in Europe the kind of first wave, so data through from March through to roughly June time. We can see this similar pattern to the United States. of the mortality rates by neighbourhood deprivation. So this is a relative index, so we can see in comparison to the least deprived, then the most deprived neighbourhoods in England and Wales have a mortality rate around twice as high, so reflecting similar data from the United States. And we can see here that it's the bottom 30% of neighbourhoods that are experiencing this, not just the very, very most deprived, but 30% of the population have these much higher rates. And we can see, I took some data from one of your recent Public Health Wales reports looking into the specifics of what was happening in Wales during the first wave, and we could see that the most deprived areas of Wales had a COVID-19 mortality rate of around 110 deaths per 100,000, which again was almost twice as high as the mortality rate for the least deprived, which was around 58 deaths per 100,000. So we can see these inequalities, and they're broadly similar in size in the United States, in England, and also in Wales, as well as in other countries across Europe. So that's looking at kind of area levels, county, neighbourhood. We can also see it in data relating to occupational inequalities in COVID-19 deaths as well. So this is data, again, relating to England and Wales between March and May, and comes from, again, Public Health England, Public Health Wales data. And we can see here which groups have had the highest mortality rates in this first wave. We can see the lowest for both men and women is in kind of more office, home-based occupations, managers, directors, professional occupations and technical occupations, so similar patterning for women. And we can see that the occupational groups with the highest mortality rates are those, for example, working in food processing, in less skilled, more manual occupations, and also in terms of people in the leisure and caring industries. And this reflects Jyoti's comments in her introduction. There is a sort of, we could see a bit of an occupational gradient, particularly for men, with the exception of these particular occupations. And we can see that the mortality rates for each group are higher amongst men than they are amongst women. Also, an important axis of inequality, as I noted, intersecting with these occupational and neighbourhood level inequalities is, of course, ethnic minority status. And we can see here, this is data from Public Health England, looking at mortality rates and diagnosis rates for COVID-19, and we can see that the Black and Black British groups, both men and women, had much higher diagnosis rates for COVID-19 in the first wave, particularly compared to white groups, and this is also unfortunately reflected in much higher rates of mortality. Again, looking at what's happened in Wales, then data from yourselves, thank you, Public Health Wales, has shown that again, it's a similar patterning with Black British men and Black Welsh men and Black Welsh women doing particularly badly in comparison to white Welsh populations. And we can see here, for example, for men in Wales from Black ethnic background was over 255 deaths per 100,000 compared to 87 deaths per 100,000 for men in Wales from a white ethnic background. I also wanted to reflect a little bit, being based in the northeast of England. I do quite a lot of work around the regional inequalities in England, and a couple of weeks ago we published a report with the Northern Health Science Alliance that looked at COVID in the north, COVID in the Northern Powerhouse, and we were again looking at the data from the first wave and looked at the regional inequalities, and we can see London had the highest mortality rate in the first wave, but then you get the northeast and the northwest then are doing the next worse in terms of mortality. And when you pull northeast, northwest and Yorkshire and Humber, what we're calling in England, or was called in England, the Northern Powerhouse, then you have an extra 12.4 deaths per 100,000 in the Northern Powerhouse in the first wave compared to the rest of England, so compared to the south of England. So we can see that there are neighbourhood inequalities, both in England and Wales and internationally. There are occupational inequalities, again reflecting on what we know from data from 100 years ago. And there are also ethnic minority inequalities, and there are regional inequalities in COVID-19. So this is certainly not an all in it together situation. Certain groups in our society, certain neighbourhoods, certain people are being far more affected by COVID than others. And that's where I want to introduce a concept of the syndemic pandemic. So drawing on work by the anthropologist and clinician Merrill Singer, he was working in urban areas of the United States in the 1990s, exploring the epidemics of substance abuse and homelessness and violence that had emerged in the cities of North America in the 1990s, and as well as HIV and other interrelated risk factors. And he argued that instead of viewing these as separate epidemics, separate issues, health practitioners and policymakers need to think about them as clustering, working together, interacting with each other and potentially exacerbating each other. And through this, he came up with the idea of a syndemic. So a syndemic is a set of closely entwined and mutually enhancing health problems that significantly affect the overall health status of the population within the context of perpetuation configuration of noxious social conditions. So if we want to put that in a simpler terms, then we can see that the health inequalities that we're seeing in COVID-19 are themselves related to the social and economic inequalities in the social determinants of health before the pandemic. And in turn, the pandemic acts syndemically to then influence the inequalities in turn. So we can see that we have social and economic inequalities. These lead to inequalities in COVID-19. And then COVID-19 in turn exacerbates those social and economic inequalities. And we can see this by thinking through some of the pathways, looking at the social determinants of health. What some of the pathways are whereby we've ended up with these inequalities in COVID-19. And I think there are at least 4 that we can think about, and I'll be interested to hear your thoughts on whether there are others. But we've identified, let's say, 4 main pathways. And the first one is around increased vulnerability. So Yoti mentioned it in her introduction. It's looking at the higher burden of clinical risk factors in certain communities and certain neighbourhoods in terms of, for example, diabetes or respiratory disease that we know are a strong risk factor for adverse outcomes from COVID-19. So we know, for example, that people live in more deprived neighbourhoods are more likely to suffer from these underlying illnesses. So that means that if they have COVID-19, they have a worse outcome from COVID-19. But what we have to remember in that discussion is that these inequalities in non-communicable diseases in turn are related to the unequal exposure to the social determinants of health, to housing, to childhood experiences, to employment and so forth, that those communities have experienced over their life course. So that's the first pathway. It's around the vulnerability of certain communities because of their long-term exposure to social and economic inequality. The second pathway is around increased susceptibility. And this is looking at how that exposure to those social determinants not only leads to inequalities in clinical risk factors, but also leads to inequalities in people's underlying immune response. So this is looking at how over time people's immune system can be weakened by living in these adverse environmental conditions. And this is drawing on the psychosocial theory of health inequalities put forward by Michael Marmot and Richard Wilkinson in the 1980s and 1990s, where they did a series of studies using the data from the Whitehall cohort, which examined the impact of being at the bottom of a social hierarchy, at the bottom of an occupational hierarchy, how that impacted on your chronic stress levels, which in turn led, for example, to higher cortisol levels and to repressed immune responses, which can then be associated, for example, with high rates of cardiovascular disease, metabolic syndrome, extreme psychological ill health, and so forth. So the argument here is that certain population groups have an increased susceptibility to the illness and to ending up to have more severe symptoms from that illness, from COVID-19 in this case. So there's increased vulnerability, there's increased susceptibility. The third pathway is around increased exposure. So Jyoti in her introduction was talking, for example, about outbreaks in Wales in food processing plants. And that's a good example of how we need to think about how people, low income jobs, people particularly, for example, working in retail or in the social care where a lot of the jobs are low paid, have been required to still go into work even during the first lockdown in March and April, the more sort of severe lockdown, even during the fire break. And so obviously they're more likely to be exposed to the virus because they're in more contact with more people than people who are in privileged positions such as myself, white collar workers who by and large have been able to work from home and have much lower contact with others. We can also see the inequalities in terms of, for example, the need to use public transport rather than a private car and how that can increase exposure. The fourth pathway is around increased transmission. And this is something, for example, that was picked up in the Public Health England report that looked at Black and ethnic minority communities, looking at whether housing conditions, for example, in places like Blackburn, where there's a lot of old Victorian terraces in poor repair, the high level of urbanity, whether that could be contributing to some of the inequalities that we're seeing. So we can think about this in terms of whether people can self-isolate if they have a positive COVID-19 test, and if they're able to exercise outside without having too much contact with others, and whether just on their day-to-day basis there is a living in a more highly densely populated area in a more urban neighbourhood, would it lead to higher likelihood of contact with others than living in a more leafy suburb. So I think there are at least 4 pathways around vulnerability, susceptibility, exposure and transmission. And I think we also need to think also about what happens when you have a COVID-19 positive test. Are you able to financially afford to self-isolate, or do you feel that you still have to go into work? So there is various structural, social and economic factors that are long-term in the background for why these neighbourhoods, population groups are having these adverse outcomes from COVID-19. And I think, in a sense, that brings us to sort of the first part of the syndemic, how the inequalities that we had before in the social determinants of health have led to inequalities in COVID-19. The next stage is to then think about what will COVID-19 itself do to those inequalities. And I think there are a number of ways, and Jyoti referred to a few of them in her introduction in terms of how we live and how we interact and so on. But I think the biggest one, the one that's coming on the agenda and is, I suppose, the one I'm most fearful of, at least in the short term, is around the economic crisis. So we could see already over the summer that GDP, so gross domestic product, national output, was falling considerably across all of Europe and the United States. We in the UK experienced the highest drop of output in the first 6 months of the year of more than 20%. Globally, we're beginning to see record levels of unemployment. So, for example, over 5 million people in the United States filed for unemployment benefit in just 1 week. And there are predictions that unemployment rates in the United Kingdom will potentially exceed 10% in 2021. And of course, that's on the levels possibly higher than the economic crisis and of the deindustrialisation period in the 1980s, which we in the North East, and particularly yourselves in the south of Wales, experienced so harshly then. So we certainly know a lot about what that is like in our relative communities. Unfortunately, there is speculation by economists that the impact could economically be greater than the global financial crisis, could be worse than the 80s, and could even be worse than the 1930s. And I'll talk a little bit about the health impacts of economic crisis, but then also what I think can be done to prevent these predictions on the economic side necessarily leading to adverse health outcomes. But first we need to think about some of the inequalities that are emerging already from the economic crisis. So we can see that there is data over the summer suggesting that in England, areas of already existing high deprivation, such as Manchester, Liverpool, Newcastle, have all experienced above average increases in unemployment over the last year. There are a couple of reports out recently from bodies such as the Institute for Fiscal Studies suggesting that the neighbourhoods with the highest unemployment before COVID would bear more of the burden of the new post-COVID unemployment. So looking at, for example, neighbourhoods where there might be over 15% of the working age population unemployed, they could see their rates doubling over the next year. Today we saw a report from the Joseph Rowntree Foundation talking about the number of children that could fall into poverty, but also into extreme poverty, into destitution as a result of the crisis, and potentially as a result of how the welfare system reacts to it. And of course, another way in which the inequality is emerging is that these areas of the country are also the regions that have the highest levels of COVID-19 cases, and are the ones that in a sense are losing out already in terms of economic growth by being put in tier 3, for example. So we can see how the emergency measures required to contain the inequalities in the virus are in turn potentially leading, for example, to regional inequalities in the economic crisis. And certainly sectors of the economy that have been most hard hit by things like the fire break and by the tier restrictions are those in which a disproportionate number of low-income workers have their jobs, so retail, tourism and restaurants. And we can see from a huge body of research dating back to the 1970s, but certainly a big amount of work done by people like Steve Platt, Mel Bartley and Steve Montgomery in the 1980s, other colleagues internationally such as Room looking in the 1990s, and more recently colleagues such as David Stuckler, Ben Barr and Aaron Reeves have been looking at the unequal health impacts of previous financial crises, of previous recessions and depressions. And we can see from that literature that economic recession leads to increases in physical, psychological morbidity and mortality. A lot of this is associated with rising unemployment. And we can see that here in terms of, this is data from Ben Barr and colleagues at University of Liverpool, and they looked at increases in the unemployment rate for women and also for men before and after the global financial crisis in 2007-8. And we can see almost a dose-response relationship, particularly for men, that as unemployment goes up, suicide rates go up. But this relationship is not shared equally. And there's evidence to suggest that after the global financial crisis, areas with higher unemployment rates had greater increases in suicide rates. And we found that people in the most deprived areas experienced the largest increases in poor mental health, self-harm and other adverse outcomes. So if we think that the economic crisis is going to disproportionately impact on more deprived neighbourhoods, lower income groups and more deprived and marginalised regions of the country, then we can see that the health effect, the example here being on suicide, is also going to be most felt by these parts of the country. However, there's also evidence that the link between an economic crisis and the link between unemployment and these poor health outcomes can be broken. The social security that we provide matters in terms of mitigating the impacts on health of, let's say, unemployment, for example. So how the government chooses to respond, whether the UK government chooses to keep the £20 per week uplift on universal credit or not, for example, can have a big impact on the inequalities that we will see in terms of health. So, for example, again, looking at data from the global financial crisis, looking across Europe, we can see that the impact of the crisis on health inequalities was worse in countries such as the UK, Italy and Spain, who went down a policy of austerity, of cutting public spending, cutting welfare benefits, compared to countries where they had increased social protection, such as Iceland, or didn't cut back on what they provided. They either had no increases in health inequalities, so they managed to maintain and not exacerbate existing health inequalities. And we can also see the other side of the coin. So when you cut welfare, you have an increase in health inequalities. But when you expand welfare, such as happened under the Labour government in the health inequality strategy of the 2000s, or as happened going back to the 1960s with the war on poverty in the United States, then we can see that inequalities in health, particularly looking at things like infant mortality rates, can decrease. So when we're in this situation of the impact of the economic crisis on health inequalities, there are policy levers that can be used to prevent increases in poor health, particularly in the most marginalised communities. And I'll just give an example here. This is from what work I was involved in, looking at what happened in the expansion of welfare, the expansion of NHS funding that happened under the Labour government's health inequality strategy that ran from 2000 to 2010. And this is looking at trends between the most deprived 20% of English local authorities and the rest. And we can see this is for mortality amenable to healthcare, so which is a sensitive measure when you're looking at NHS expenditure, for example. We can see that the inequalities decreased significantly during this period. And here on the right hand side is looking at trends in inequalities in infant mortality rates over a longer time period. And we can see that again, the gap significantly decreased during the policy period. I've subsequently been involved in some more work that's looked at the increase in infant mortality rates that's happened over the last 5 years, and we found a strong association with increased rates of child poverty since 2010. So again, this data is confirming the view that how we intervene in the social security system can stop the COVID-19 economic crisis from becoming yet another health crisis. So I'm just going to conclude here so that we have some time for questions. So I've talked a bit about the nature of health inequalities in COVID-19. And we get this rate where it's broadly double in the most disadvantaged communities. That's something we see in England, we see it in Wales, we see it in the United States and in other countries. COVID-19 is an unequal pandemic, just like previous ones, just like Spanish flu 100 years ago. I've argued that we can understand these inequalities through the concept of a syndemic pandemic when we look at the interaction of non-communicable diseases, social and economic inequality, and the social determinants of health. The coming COVID-19 economic crisis may further exacerbate these health inequalities, but the social policy that we implement, the social security system that we use to support people who are experiencing poverty and unemployment as a result of the crisis, how we use that tool, that is a public health tool that could prevent increased inequalities. There are a number of recommendations that flow from these kind of ideas. And obviously we need to think about how we can reduce inequalities in COVID-19 itself, for example, through the vaccination programme. I've talked more about what we can do on the economic crisis, but of course, in the longer term, when we're thinking of potentially preparing better for future pandemics, then we need to go back to our day-to-day public health practice around chronic disease and health promotion. So I'll end there and hand back to Yotti and just say thank you for this opportunity, and I look forward to discussions and questions.
Thank you so much, Claire. That was really, really interesting. We haven't had any questions posed by the audience, and it may be because people aren't sure how to ask questions. Andrea, would you be able to explain that to people?
Yeah, sure. If you go to the top right of your screen, there's two little boxes with a question mark in the centre of one of them. If you just click on there, you can enter your question in the chat box there, and that'll come through to us.
So in the absence of others asking questions, I'm afraid, Claire, you've got me asking you questions. So one of the things that you didn't mention in your description of the potential differential risks was behavioural risk factors. We know we've had high rates, particularly in Merthyr Tydfil in Wales, which is known to be a relatively deprived area. And one of the things that we think might have contributed to that increased risk, apart from the others that you described, is that they're a very close-knit community. And I think that there's a hypothesis that they were continuing to socialise during lockdowns, etc., which may have increased risk. Is that something that you've considered in your work?
Yeah, so I haven't. I mean, I've also sort of heard about those sort of things in similar, former mining communities up here in Durham that are broadly comparable with Merthyr, and I think there is anecdotal evidence for that. I guess that would explain higher cases, but when we're standardising, then the worse outcomes would still be related, I think, to the underlying risk factors that people have. And I think it's difficult, kind of in some ways sympathetic, because I think you're more reliant on family and community ties in those when you're struggling to balance off and still trying to get into employment and trying to get by, because we're talking about communities that are already suffering from a lot of poverty and unemployment beforehand. And also people are being told to go to work, so they can see people at work, but then they're not allowed to see their mum. And I think that comes down to some of the poor messaging from, I mean, I can't talk about the Welsh case, but certainly from a UK government case. I mean, I can remember in August, early September being told, go back to work, Claire. So I went back to work for a couple of weeks, and then, oh no, don't go to work anymore, start working from home. So I think sending out these mixed messages, okay to go to work, but it's not okay to see your mum or to see the person you saw at work. You can't share a car home with them. And I think there hasn't been enough explanation, certainly in England, of why certain things have been done. So if we look at the tiers now, why is it okay to go into a crowded shopping centre, indoor shopping centre, and queue and shop around for hours, but it's not okay to go with a member of your household into a restaurant? And I think that's where a lot of the messaging was lost, and obviously a lot of mixed messaging over summer. Eat out to help out, it doesn't matter if you have 6 people at your table, or does it matter if that 6 is 10? I think we were assuming far too much knowledge from people on what the restrictions were and how they seem to change day by day. So I accept that that probably is part of why cases might be higher, but I can also see why that behaviour might have happened, both on the behalf of those communities, but also I see it as a bit of a failure from a public health messaging perspective, actually. Yeah.
We did have one question pop up from the audience, and that was around the type of contracts, employment contracts that people have. Have you looked at that at all? Looked at the data around that?
No, I haven't looked at that data at the moment. So my kind of approach has been to kind of theorise what the pathways might be, but I've just got a grant from the Health Foundation that will be looking at why these geographical inequalities have occurred. And we will be trying to collate certain data for each region, for example, on percentage of people on, temporary work compared to full-time secure work, all those kind of things. But certainly that's something to add into the mix, because again, it's about people feeling whether they can self-isolate or not, whether they can afford to do so. So I think it's an important point. Yeah. Okay.
No other questions from the audience yet. So another one from me, I'm afraid.
Well, yours are tough, so
One of the things that we've observed from our data tracking COVID trends over time by deprivation quintiles is that during the lockdown, so before lockdown, there were wide inequalities in both numbers testing positive and hospital admissions. As we went through the lockdown, rates went down completely across all deprivation quintiles, and so had the impact of reducing inequalities. But there's a paradox there in what you presented, in that, yes, it did reduce inequalities in COVID acquisition, but the consequences post-COVID will be disproportionately felt by those in those poorest areas. Do you have a view on the trade-off between those two?
Yeah, so I think I've tried to make a case for it not being a trade-off, because obviously that is after the Great Barrington Letter, and they were trying to say, don't bother doing any restrictions, just crack on. then there was a bit of a debate, wasn't there, for a few days in the press about whether it's health versus wealth or whatever. And I think what we do economically in response to crisis matters. So providing support for people who lose their job as a result of the crisis, or for any other reason, but also thinking about how you invest in those parts of the country, those neighbourhoods that have suffered most. So we have the levelling up agenda, after all, that should be used to support investment into the regions, into Wales, etc.
Okay. We've had a note from one of our colleagues here who's said that we have looked at different contract types in Wales, and she's happy to share that.
Oh, that would be great. Yeah, thank you. Yeah.
There's some questions that are coming up that are similar to something that I wanted to ask about how we deal with the consequences, the long-term consequences on employment and people falling out of employment and income. And we're debating what we do about that, and some of these are policy options, aren't they? Austerity, etc., is not inevitable. We have choices that we can make, and we've been a little bit focused on employment and unemployment and how we address that. But with the best will in the world, there will be increased employment. And I was taken with your arguments about ensuring there's a strong safety net. Should we also be trying to stimulate the economy and create good employment alongside that, or just focus on the safety net?
Mm-hmm. Yeah, so I mean, obviously I'm not an economist, but I would certainly be sympathetic to arguments about trying to stimulate through central government action, and certainly you can see how that was effective in the 1930s. And if economists are drawing the parallels between now and the 1930s, then obviously the kind of New Deal Roosevelt approach significantly stimulated the US economy. I mean, other people would argue the Second World War and rearmament was also a factor, but nonetheless, it's still investment in production or whatever. And I think the government has talked a lot about this, and early on they tried to make parallels with, the kind of war effort and the home front, and how we all had to, take that on and take it, the lockdown, etc., for the team, etc. And we can follow that through and say that actually, we were still paying for the war under the Blair government, right? The debt that we owed the US. So this is on that scale. So therefore, the debt that we've accrued as a country to pay for COVID, to pay for furlough, to pay for universal credit, etc., that should be done over a 50, 100-year basis. We don't have to pay it all back tomorrow. You don't pay for your house all in one go. You have a mortgage. A lifetime debt is what a mortgage is, till death. Yeah. So that's what we should be doing here. We shouldn't be putting all the burden on the next 2 years, because then we've got nothing to spend. That's the NHS, on social security, etc.
Thank you. One of the questions that's been posed is what can we do at a national and local level to deal with some of the implications that you've presented? Do you have any suggestions for us?
Well, there was quite a bit in my talk, so I guess we maybe need to think about what we can do in the long term about inequalities in the underlying clinical risk factors. So that's back to our kind of bread and butter, isn't it? Of how do we go about carrying on to get smoking rates decreasing, particularly in poor communities? How do we focus up our efforts on that around alcohol? I think those longer term investment in public health, which has been lacking from successive governments, but obviously we've had budgets cut for our local authority public health teams in England over the last decade. So reinvesting into public health so that we have a population better ready to withstand if there is indeed another kind of zoonotic crisis in the future.
Thank you. I'm just taking a moment to see the questions coming up. How can we address social networks? How can we promote social networks to deal with some of the consequences that we've seen? Have you looked at mental well-being at all in any of your work and the consequences of lockdown measures on mental well-being?
I've seen some work that's been done on that, and one of my colleagues is doing some work showing obviously the negative effects that we would expect based on our knowledge of mental health and well-being from public health community. And I think it's going to be difficult to see how we can, I don't know, it's speculation as to how can they be rebuilt. I think when people feel able to, government allows people to socialise a bit more once the vaccination rates are up amongst the more vulnerable elderly people, then it's hard to predict how people will then go about, because some people, it's going to be a gradual process, isn't it? Some people are still going to feel quite vulnerable because they won't have had the vaccine, might be worried about long COVID and things like that. And I think maybe a lot of this isolation, I think by the time most office workers are back in the office, they might have been by and large working from home from over a year. So the nature of your social interactions completely changed. So whether it's a revolutionary moment and things completely change, or whether we're also desperate to get back to how it used to be, I think that still remains to be seen. Yeah,
I think the social isolation challenges that we face will probably go over the next 3 to 6 months, but then we'll have another wave of mental well-being impacts, like caused by unemployment, income loss, housing tenure, etc. That will probably be deeper and longer lasting than what we've just seen.
And will affect the people that we've been talking about.
Absolutely.
More than others, you know. When the rich elderly are allowed out and about again, they'll be all right, won't they?
I shall call it a day there in terms of questions, and thank you so much for your time and your really interesting presentation. I think it resonates with what I've seen in terms of COVID consequences here in Wales, as you heard from my introduction. I just wanted to remind the audience that there will be a post-presentation survey, and we'd really appreciate you taking the time to fill that in. We do take notice of what you say to us and try to improve the experience for you. Also to ask you, if you're not a member of the network, to sign up to the network. And if you do, you will receive our e-bulletins and information about future events. So thank you all so much, and especially you, Claire.
Thank you. Thanks so much. Okay, see you soon. Bye, everyone.
Bye.